Will begin with calculation of reabsorption and secretion rate. The calculation of reabsorption and secretion rate. So we have something called the filtered load. Filtered load equals the glomerular filtration rate multiplied by plasma concentration of substance. Then excretion rate, which means VV, urine flow rate multiplied by the urinary concentration of the substance. So if there is filtered load, so you will need what? You will need the glomerular filtration rate and you will need the plasma concentration of this substance. And if there is excretion rate, so you will need what? So you will need urine flow rate plus the urinary concentration of this substance. Then we spoke about the reabsorption and secretion and filtration and excretion. So the reabsorption rate equals what? In case of filtration more than the excretion. So filtration minus excretion equals what? Equals the reabsorption from the tubule into the afferent artery. Then we have the secretion rate in case of increase in excretion more than the filtration. This means what? There is secretion from the afferent arteriole into the tubule. So again, reabsorption means what? The filtration more than the excretion. So this amount will go into the reabsorption from the tubule into the afferent arteriole. Then there is secretion means what? Excretion more than the filtration. So the difference between them equals what? The secretion from the afferent arteriole into the tubule. Then we have Fe sodium. F means what? Fractional. E excretion of what? Of sodium. So Fe sodium means the fractional excretion of sodium. So how to calculate Fe sodium, fractional excretion of sodium? So it's what? It's excretion. So you will calculate sodium excretion divided by sodium filtration divided by sodium filtration. So fractional excretion of sodium. So sodium excretion divided by sodium filtration. So we know that excretion equals what? We spoke about it. Excretion rate equals what? You need urine flow rate, which is the V multiplied by the urinary concentration of the substance. So you have the V and urinary concentration of the sodium. This is the excretion. Then you need what? Sodium filtration. We spoke about it. The filtered load filtration is what? You need the glomerular filtration rate and plasma concentration of this substance. So glomerular filtration rate and plasma concentration of this substance. So you have the excretion of sodium V urinary flow rate multiplied by the urinary concentration of sodium divided by what? Divided by the filtration equals the glomerular filtration rate multiplied by the plasma concentration of the sodium. Then you know this equation. Glomerular filtration rate equals what? U multiplied by V divided by B. But in case of what? In case of glomerular filtration rate, it's measured by what? By the creatinine. In case of renal plasma flow, it's measured by what? By the para-aminohippuric acid. So what you need here is what? Is glomerular filtration rate. So glomerular filtration rate equals the urinary concentration of the creatinine multiplied by the urine flow rate divided by the plasma concentration of the creatinine. So you will take this part and you will put it here. Instead of the glomerular filtration rate. So you will put what? The urinary concentration of creatinine multiplied by the urinary flow rate. So you will put the urinary concentration of creatinine. Then you will put the V. Then you will divide it by what? By the B creatinine. This is the B creatinine. So where is the V? V removed with the other V. Removed with other V. So the remaining part is what? Is the urinary concentration of creatinine and plasma concentration of creatinine. So this is the urinary concentration of creatinine and plasma concentration of the creatinine. creatinine, and then the remaining part which is here urinary concentration of sodium divided by the plasma concentration of sodium divided by the plasma concentration of sodium. So the final one for fractional excretion of sodium, fractional excretion of sodium is what is plasma concentration of creatinine multiplied by the urinary concentration of sodium divided by the urinary concentration of creatinine multiplied by the plasma concentration of the sodium Then the next one is what? Glucose clearance. This is so important for this part. So glucose clearance is what? We have the plasma glucose level, and we have the glucose transporter. So glucose transport means what? Sodium glucose co-transporter in proximal convoluted tubule. Sodium glucose co-transporter in the proximal convoluted tubule. So the plasma glucose normal between what? Between 60 to 120. So this is the normal. So the glucose will not appear in the urine. So there is a threshold. This is the threshold, which is what? Which is 200. So from 200 the glucose will begin to appear in the urine. Why? Because there is saturation of some sodium glucose co-transporters, a saturation of some of them until reaching 300, this part 375, which is called the TM means what? This part means what? Means there is saturation of all sodium glucose co-transporter. So the renal threshold is that the glucose will begin its appearance in the urine is what? 200, and some co-transporters will be saturated and others will not be saturated. So some of glucose will be reabsorbed and others will not be reabsorbed and will appear in the urine at the beginning of what? 200 until reaching to 375, which is the TM. By reaching out 375, this means there is the complete saturation of all sodium glucose co-transporter. So any glucose after this threshold, which is 375, all will appear in the urine. So there is a transition from 200 into 375. This is the curve of transition called display. This transition means what? Some of sodium glucose co-transporter saturated and others are not saturated. So the glucose will appear in the urine, but not all the glucose. So some of glucose will be reabsorbed and others will not be reabsorbed. So some of glucose will appear in the urine and others will be reabsorbed. So until reaching the 375. So all sodium glucose co-transporters will be saturated. So all glucose will be excreted. All glucose after 375 will be excreted. So reabsorption will be inhibited completely at 375, and all will be excreted. From this moment, which is 375 until reaching 400. So it's what? But exactly it's 375. It's 375, which is called TM. So all sodium glucose co-transporters are saturated. So there is complete inhibition of reabsorption and the excretion of all glucose after 375. So this is the filtration and this is the excretion that will increase after 375 because there is no reabsorption of glucose after 375, but it's slightly increasing here, which is opposite to what? Opposite to splay. What's meant by splay? The transition from the renal threshold, the beginning of appearance of glucose in the urine, because there are some receptors, some co-transporters are saturated and others are not saturated until reaching complete saturation of all co-transporters at the point of 375. So the excretion of all glucose after this point, after the TM point, but there is complete inhibition of reabsorption at the TM point also. So we will speak about this. So glucose at normal plasma level from what? From 60 to 120. So it's completely reabsorbed in proximal convoluted tubule by sodium glucose co-transporter. So all will be reabsorbed by sodium glucose co-transporter in proximal convoluted tubule. Then in adults at plasma glucose nearly 200, glucosuria will begin the threshold, the renal threshold. It will begin at but at rate of 375, which is TM. All transporters saturated at the point of what? 375. So all glucose will not be reabsorbed. All glucose will go to the urine. So there is transition from 200 into 375. Some receptors are saturated, others are not saturated. So this is called what? Splay phenomena. So TM for glucose is reached gradually, then rather than sharply. Sharply means what? Sharply means if you reach out the renal threshold, so there is no reabsorption. So it's not happening. It's not right. It's gradually means what? Means some saturation of some receptors and others will not be saturated during splay phenomena, during transition from the 200 into 375. So it's gradually. Why? Because there is heterogeneity of nephron. Some nephron sodium glucose co-transporter in it saturated early, and others will not be saturated until reaching to the TM, which is the 375. So all will be saturated at the TM. So there is different TM points represented by the portion of titration curve between the threshold and TM. This is the threshold, between the threshold and TM. What's meant by the threshold? It's 200. The TM is what? 375. So the TM is different because of heterogeneity of nephron, different from one nephron to another, but all will be saturated at what? At 375. There is heterogeneity in them, but there is no reabsorption anymore after 375. So all will be excreted in the urine. So glucosuria is important clinical clue for what? For diabetes. You will do any investigation for check the diabetes. Microalbuminuria is so important. Microalbuminuria for diabetes. Then the next one, normal pregnancy. There is what? There is 50% increase in plasma and 30% increase in RBCs. So there is more expansion of plasma by 50%, more expansion in plasma during pregnancy. So it's associated with what? Increased glomerular filtration rate, increased filtration of all substances, including what? Including glucose. The glucose threshold occurs at lower plasma glucose concentration. So we said that the renal threshold is 200. It will be lower during pregnancy. There is expansion of the plasma, more filtration, including glucose. So the glucose threshold occur at what? At lower plasma glucose concentration, leading to glucosuria at normal plasma glucose level, and it will be normal during pregnancy. So glucosuria can occur at normal plasma glucose level during pregnancy due to expansion of the plasma and filtration and increase in glomerular filtration rate, increase filtration of many substances. One of them is glucose. Then we spoke about this co-transporter is so important, sodium glucose co-transporter. So in diabetes there is what? There is a treatment called what? Canagliflozin, dapagliflozin, which is sodium glucose co-transporter 2 inhibitor, leading to inhibition of reabsorption of glucose, leading to glucosuria at plasma concentration less than 200, which is the threshold, because you are using a drug that will inhibit reabsorption of glucose through the sodium glucose co-transporter, leading to glucosuria at plasma concentration lower than the threshold, lower than the 200.